us are dealing with what do we do with our advanced cardiac patients as they near the end of their life. And there are a lot of things that we have done to them that we have to consider when it comes to the time that they are nearing their time with us, and it may or may not involve some of the therapies we've implemented. My disclosure slide. So what we're going to do today is talk about what types of devices that myself and my partners end up putting in patients and what that means to them. Some of the legal guidelines, what we can do and what we cannot do for patients, how we probably feel about those decisions. There's a lot of ethics that goes into end of life, and there's also a lot of personal preferences that go into that as well. And then how do we discuss these things with our patients and provide them with the information they need to make the best decisions. So I'm going to start it off with 3 different cases because that's kind of how I think about my patients. And I'm going to start off with, if this were your family, what would you do? Because that's what happened to me during my general cardiology time. My grandfather was a wonderful 80-year-old gentleman, and unfortunately, you can see he had a lot of medical problems and had become quite disabled. But related to me, he had complete heart block and had a permanent pacemaker, and unfortunately, he was diagnosed with invasive esophageal cancer. When he was admitted, someone came in and said, I'm going to give you a palliative trach, it's the right thing for you, good luck, and signed off the case and said to the family, have at it. I won't even speak to how I feel about that. But so here was my grandfather with a trach that went into hospice where he proceeded to have his life-ending event for the next 6 to 8 months. Ultimately became unresponsive from infections and other things, and I received a call from my family saying, we can't take this anymore. Can we do anything to reduce his suffering? Would you help us turn off his pacemaker? He is pacemaker dependent. Without his pacemaker, we'll have an asystolic arrest. Another patient that came to me, I'd been here for about 2 months, and I inherited some of Dr. Kushner's patients. And so there was a device interrogation on my desk one day, and it said, patients at end of life needs a new battery. Unfortunately, had been end of life on his device for 3 months already, and I looked into his chart and saw that he had advanced myelodysplastic disorder. His white count was less than 0.5. He was anemic with a hemoglobin of 6. His platelets were less than 10. He'd been given about 6 months to a year to live, but he needed a new pacemaker. He'd already met our threshold of changing it out by 3 months. And so if I did not change out his pacemaker, he was going to have an asystolic arrest. What did he want me to do with the risks of me taking care of him versus how do you want to die? He was actually a really, really nice gentleman and was very, very involved. So him and I had this long discussion about, if I do surgery on you, here are the risks of the procedure. If I do not do surgery on you, this is what death will be like from your pacemaker stopping. And ultimately the question was, how do you want to die? The last one we come across this all the time in the hospital is a patient with advanced heart failure, coronary disease, low EFs, have devices in place, ICDs, ICDs, getting readmitted for their umpteenth episode of heart failure or whatever other organ is not functioning at the time, and he's on multiple antiarrhythmics, recurrent infections. You know the drill, you have enough of these patients. What should I advise him regarding his device? Should I turn off his ICD? Should I turn off IV pacing? What is the best options that I can provide him with? So pacemakers are both life-saving and life-sustaining devices. So they are well known for saving patients' life, particularly those who have had asystolic arrests. They are also life-sustaining, so they can prevent other events from occurring. Although this is a very small portion of our patients, not everyone is pacemaker dependent. A lot of times they have pacemakers for symptom control. It is not necessarily just as a death prevention. A lot of them just have symptomatic bradycardia that we make feel better and actually improve quality of life with those devices. And of course, we can have symptom improvement for heart failure patients when they have IV devices in and we resynchronize their heart. And that in and of itself can make patients feel better, reduce their arrhythmia burden, and have better outcomes for them. ICDs are life-saving devices as well. So these are well known to extend life and prevent sudden cardiac death. We implant them in patients either with a history of cardiac arrest or sustained ventricular arrhythmias, and they will protect against sudden death due to arrhythmogenic etiology. They will not stop death, of course, from any other etiology, and we put these in patients that are at highest risk for having recurrence. When we implant them just as primary prevention, it means we think something might happen to you. You're at high risk of it happening to you, but it has not yet occurred. Then, of course, we can combine these therapies with any of our pacemaker therapies to give them the device that is best for them. All patients will die. We all know that. That's not earth-shattering. The problem is, what do we do in them when we have these devices in place? What is their cause of death going to be? Is it going to be from a cardiac etiology? They're dying from end-stage heart failure. There's nothing more we can do to revascularize them, to improve their blood flow. Are they having incessant ventricular arrhythmias that, despite every antiarrhythmic we've given them, the ICD cannot prevent the arrhythmias from occurring? So at what point is the device no longer changing their outcome? And they can also die just from having an acute MI. A lot of times these patients, though, are dying from other reasons. Is it that they're coming in with cancers, infections, strokes, all of the other leading causes, but the device is also there as a backup measure. But 20% of patients with an ICD will receive a shock in the last month of their life, independent of their cause of death. Shocks hurt. People don't like it when it actually happens. And if it happens when you're already going through the dying process, it's not a great way to have your end-of-life event, and it's really scary to them. Once people have had their first shock, they're often fearful of what's to come next. They're fearful of the next shock. They're fearful if the device doesn't save them, what will happen? And it causes a lot of distress to both them and their families to see these types of events occur. So when it comes to the legality of what we can do, the bottom line is patients have autonomy and they are the ultimate decision maker, or of course they're activated by the power of attorney. We have a responsibility to provide them with informed consent. They make the decision, we just inform them, but it is a heavy responsibility on us to be informed about how we provide that information. And just like any other type of medical care, they have the right to decide what they receive, as well as decline whatever we may or may not recommend for them. And it's easier for us when a patient says, I'm going to decline the implant of a pacemaker. I'm going to decline the implant of a primary prevention ICD. I understand what that means and I don't want it to be done. But they also have the right to discontinue anything that we have already done for them. And devices are considered no different than a ventilator, than dialysis, than anything else that we do to patients to treat an underlying etiology. And so it should not be viewed differently, although I have to tell you in our hearts we often feel very differently about it. So the hardest thing, and it happens very rarely, is when patients want to terminate a therapy when they are not in our eyes terminal, but they still have that right to do so. Just as if a patient came to you and said, I do not want to have dialysis anymore, even if they're not actively dying at the time, you cannot force them to go to dialysis. For us, we really struggle between letting someone die and being involved in their death. And that's where it becomes difficult sometimes with cardiac devices, particularly pacemakers. But the bottom line in the legal arena is it's all about our intent as physicians on what we are doing for our patients. Our intent when we discontinue a therapy that we have started is not to kill our patient. Our intent is to stop the therapy that they no longer desire to have and to allow the natural course to progress. That may be that if they have sinus node dysfunction or complete heart block, that is their disease. And without the pacemaker, that is still their disease. And if they die, they are dying from that disease. They are not dying because you killed the patient by stopping the pacemaker. The intent is, I am withdrawing therapy that you do not want to have. I am not actively killing you. There's a big difference in when somebody gets a lethal injection with the intent to kill a patient versus I'm following your wishes of what you want me to do. So a lot of times, like I said, it can either be from sinus node dysfunction, which is the hardest one, or it could ultimately be allowing VT or VF to result in the patient's death. And we have an ultimate obligation to our patients to not abandon them, and that we need to, help them out. And if it's not in line with your views, you are responsible for finding someone else. And there are a lot of people that struggle with terminating pacemakers. and that's okay. But if that occurs with your patient, then you are obligated to find someone else. Because if you continue something without them wanting, even if you initiated the therapy, it is considered battery to continue. The big part about this, though, is that it's not so easy to just turn off devices. You have to make sure that you have a comprehensive approach involved, and we are responsible for making sure that that occurs. So if your actions with the device will allow the natural course to progress immediately and death is imminent, we need to make sure that we have a plan in place to provide comfort for that patient, because at the end of our day, we do no harm. And we do not want our actions to result in pain or suffering for that patient. We are people that take care of other people. And that's why these things are very, very difficult for us. And I think that we struggle a lot with the termination of life. And there can be a conflict between what we want and what our patients want, and what we think is terminal and what they think is terminal. And because death is not reversible and you can't go back a week later and say, I'm sorry, I'm going to turn your ICD back on, it's very, very difficult for us to do that. But the bottom line is they are autonomous, and we will not harm the people that we take care of. And it is a lot easier, like I said, when a patient declines than when they want withdrawal of something. There's a big difference sometimes in how we terminate therapies. So an ICD, a lot of times the therapies are intermittent. The patient's not walking in and getting, unless in rare cases, they're getting shocked and shocked and shocked. Most of the time it's like that patient that I described where they've had a history of ventricular arrhythmias. They may have been shocked previously. But if I go in and turn off their ICD, it's as though nothing happened. There may be an event in the future that will result in death, but my encounter with the patient does not change that patient's outcome in that moment. On the other side, if the patient is pacemaker dependent, if I walk in and terminate therapies, that has dramatically changed what is about to happen to that patient in the next minutes to hours to days. Some things to consider is that patients will die from other causes, even with a pacemaker in. You don't have to turn off a pacemaker to allow their natural course to occur. If you are dying, you are still going to die, independent of what that pacemaker is actually doing. Terminating the pacing, in some cases, can actually cause increased suffering, particularly if you have a biventricular pacer in. You turn off pacing and the patient has increased heart failure symptoms. So you want to be aware of what could happen with the termination of those therapies. And the problem with pacemakers is we're not worried about harming the patient. So if you're dying and you're getting paced, it doesn't hurt you. If you're dying and getting shocked, it hurts you. And so sometimes it's harder to tell people what the difference is between pacing and shocking. Discussions with patients are really ongoing when we put in devices, and often we don't have a lot of discussion, particularly with pacemakers early on, but sometimes we need to make sure in certain patient populations we address it early. We need to discuss what the expectations are from a device. Is this a device that is a life-extending, a quality of life device, and what can we expect from it? What's the risk of inappropriate shocks, giving ICD shocks for AFib with RVR, shocks at the end of life, and that death will still occur despite having something in. When they start coming in with events, particularly from their ICD, we need to readdress their expectations. If they have recurrent VT, what are we going to do? And if they have recurrent admissions, and that's when you start bringing up these conversations. This is what we're going to do if something happens, what do we do later? And then once again, once a DNR order is placed, particularly with ICDs, we want to have a goal-directed conversation. It's often DNR, DNI, but no discussion about the device. And you need to have the discussion that involves the ICD as well. If you are moving towards palliative care, comfort care, is it really appropriate to still have a defibrillator on for a patient that is seeking to have comfort at the end of their life? And it's often beneficial, and I think we're really fortunate to have palliative care here to get them involved so that we can bridge that gap of care and make sure that patients have the comfort that they need and deserve at the end of their life. Because a lot of times the question is, what will death be like from a cardiac event? What is this going to feel like? If you turn off my device and I go into VT, what will happen? If you turn off my pacemaker and I stop pacing, what will happen? And they want to know what to do with that. When we deactivate devices, I just want to say there's a few things. We have to have orders in place in the chart, documented discussions by the patient and the family with the physician. Vendors are able to turn off ICD therapies, but they cannot touch pacers, because if a patient is pacemaker dependent, they are not a physician and they cannot do anything that could allow a natural course to be imminent. So they can program it and have somebody come in and do the work for them, but they cannot actively turn off a pacemaker. It has to be done by us and usually needs to be done with hospice. So regarding the 3 cases that I showed you at the beginning, to let you know what happens. So the patient with his ICD, 5E ICD, after a long discussion, he decided to seek palliative care. His ICD was turned off, but I left his 5E pacing in. I wanted him to be free of heart failure symptoms as he neared the end of his life, but not to be shocked if he were to have another ventricular arrhythmia. In the gentleman with the myelodysplastic disease, after a long discussion, he said, "Doc, I know I'm dying. I would rather die from an asystolic death because I'm waiting for my bleeding event, and that's going to be horrible. I will take asystole where I fall asleep, where I pass out, and that's done." And in the case of my grandfather, as difficult as it was, after speaking with the family, they did wish for termination of his pacemaker, and I did coordinate with his cardiology, and I did turn off the pacemaker in a pacemaker-dependent patient and allow him to die from his natural disease, which was the cancer that was causing his death. And he died peacefully in the hands of hospice without his pacemaker pacing. So we have a responsibility for everything we do to our patients, and we need to remember that what we have done, we need to address later in their courses. And patients may change throughout their clinical course, and the discussions will have to change with them. The patient we put the defibrillator in 20 years ago is not the same patient with the same comorbidities today, and we need to make sure that we give them all the care that they deserve.